So we are going to discuss the diaphragm, kind of issues we'll find, how to find them, how they affect other parts of the body, and how we make corrections when we do find them. Just a quick reminder, this is Applied Kinesiology Session 6. 100-hour course, 2019-20, Southwestern College of Naturopathic Medicine. This is the video version. The diaphragmatic anatomy is very extensive. There is a central tendon that the muscle attaches to from the whole periphery of the torso, the spine, the ribs all the way around, and then of course the sternum. The diaphragm also has to allow passage for the aorta, the vena cava, the esophagus, other nerve, neural tissue, and essentially it interdigitates with the psoas and the quadratus lumborum, as you can see in this slide number 4. There's another slide that kind of gives a view. I've taught yoga for many years, and the psoas, of course, is very important in looking at core strength and many of the postures. And of course, the diaphragm is of utmost importance because it's one of two muscles that contract continually our entire life. If either the heart or the diaphragm stop contracting, our life ends very, very abruptly. And what's interesting is when you look at the overall deep myofascial train formed by the diaphragm is like this big dome that separates the upper and lower torso. And then as the dome comes down in the back of the body cavity, it sort of flows into the psoas, which lays down along the back of the body cavity and then comes into attaches into the hip. So there's this very intimate relationship between these structures to where functionally their function as well as their anatomy is intertwined, I guess is what I'm trying to say. The obvious function of the diaphragm is to create a vacuum in the upper thorax to facilitate air coming into the lungs. It also creates positive pressure in the lower abdomen, which is essential for moving the fluids around within and around the gut, liver, as well as moving lymph. The lymph is moving from the lower body north against gravity much of the time. And the lymph, as well as the venous blood, relies almost completely on contraction of muscles, relaxation of muscles to pump those fluids through the one-way valves north. Diaphragm plays an enormous role in that. So in Chinese medicine, of course, the diaphragm is where is the primary pump of the qi. Okay, so slide number 7. So I've summarized all this at the end of this presentation, but we'll go through some of the details. The way students are always asking me, well, how do I know if there's a diaphragm problem? How do we know if we look for it? Well, when you're evaluating, doing your basic orthopedic neurological evaluation, and then you're moving into your AK evaluation, where you're using muscle testing and other kinds of measurement. There's some pretty straightforward ways to determine if the patient is really breathing properly. And I would have to say that more often than not, our patients are not breathing properly. They're not breathing optimally. Typically, they're breathing in and out through their mouth. A lot of times they might breathe in through their nose and out through their mouth. A lot of breathing techniques teach that, which I don't think is the optimal way to breathe. I think optimally we need to breathe in and out through the nose. This keeps the CO2 levels up to the right level. It keeps I think it allows the patient to fill the lungs more fully, to contract the diaphragm more completely. Basic test is vital capacity. The average patient, the average person should be able to hold their breath for 40 seconds, at least. And that's a pretty easy thing to test. And usually very often they can't. Also, you can palpate rib expansion as they breathe in and out. I'll demonstrate that when we do the demo. You can measure it. It's very easy to take a cloth tape measure and measure the patient in full exhalation and then measure them in full inhalation, and they really should go up about an average adult should go up at least 4 centimeters, and that's quite a bit actually, and a lot of times folks aren't expanding that much. Also, whenever you find, and I'll summarize this at the end, whenever you find imbalance in the psoas, and of course that will always go along with gait imbalance, and often it goes along with pelvic issues, and often you'll find cranial issues with that, possibly switching and various things of that nature. Then you want to suspect that the diaphragm is being impacted as well because of the psoas, the psoas effect on that part of the spine where the psoas anchors, or where the psoas and the diaphragm anchor. Also, looking at the meridian system, when we use that fourth pulse point on each wrist, which Dr. Goodhart determined, taught us that it related to the CV and GV meridians. Then you want to also, it's very quick to evaluate the diaphragm at that point. You can use a spirometer or any other device that can measure vital capacity. And of course, Snyder's test is having the patient blow out a match 6 inches from the mouth with the mouth open. There's chest cage expansion measure. Should be above 4 centimeters in an older patient, above 8 centimeters in a younger patient. If you don't take the time to measure it or don't have a tape measure handy, just place your hands on the rib cage on both sides laterally, just lightly, and have them breathe in and just several times and feel that motion. And this is a good way to monitor your correction too. If you're correcting psoas imbalance or doing adjustments in the spine aimed at helping to normalize diaphragm function, this is a good before and after palpatory technique as well. This, I'm not sure. For some reason, I don't remember the thiamine connection here on this slide number 10. Breath holding time is believed if it's below 5 seconds, which that's pretty low. Yeah, I'm not sure. I honestly, this isn't one of my slides, and I'm not sure what they're going for here. I guess someone determined that this was a way to kind of break down, different kinds of diaphragm imbalances. Diaphragm therapy localization is very effective. The typical place that we therapy localize is just under the xiphoid process. Now, one way we can do that is to have the patient breathe in and out. You start with a strong indicator muscle and have the patient breathe in and out, and they may or may not weaken. If they weaken, then you can suspect, of course, without even TLing, you can suspect diaphragm, you can suspect cranials. But if the breath in and out doesn't seem to, but you're still not convinced you're still not convinced that there's not a problem with the diaphragm, we'll have the patient therapy localize at just under the xiphoid, and then retest breath in and breath out. And a lot of times that will bring up, a 51%er. And then you can use that to monitor your other corrections. I would have to say the psoas is probably my favorite way to evaluate the diaphragm. If a psoas is weak, it can be weak for a lot of different reasons. But one of the first things I'll do is have a patient breathe in and hold the breath. And if the muscle turns on right away, yes, there's probably some cranial involvement. But then a lot of times I go right to the diaphragm and see what's going on there. And a lot of times it's just a fixation at the the TL junction, a very common place for fixations, or maybe a rib out. And there may be other reasons why that psoas is weak, but a lot of times that will lead you to diaphragm evaluation. The Chapman reflexes can also be therapy localized, and that's over the entire length of the sternum in the front, and then the 10th rib just lateral to the spine, the 10th, 11th rib area will TL, and of course that can be other things too, but a lot of times that's a way to lead you into further tests for the diaphragm. The neurovascular points, there's three. There's the bregma, which it shares with several other muscles. Remember that the bregma is for neurovascular points. It's where the heart, lung, and brain related muscles have their Bennett point or neurovascular point. Then also 2 inches above the lambda, which is the midpoint of the lambdoidal suture, where the lambdoidal suture intersects with the sagittal suture. And then the lambda itself, so 2 inches above the lambda and then right at the lambda itself. The stress receptor is right above the eyes on the forehead. Treatment, well, once again, we go back to the psoas, check for hypertonic psoas on the side of decreased rib motion. And that will be an evidence by a leg, foot, hip that fails to turn in the same as the other side. So it'll look like a lack of hip turn in. Now that can also be a tight piriformis, but often it's a tight psoas, or it can be both. So that's one really good presenting finding that can lead you to diaphragm. Another, or that can lead you to fixing the diaphragm imbalance. Another one, of course, is a QL. And if we went back to that slide here, I tried to make this so you could see the proximity of the psoas and the QL. I mean, they're right there. So anything that goes awry with those muscles is going to potentially affect the diaphragm on that side. So check psoas, check QL, and then fix what you find. Also, remember the motor supply for the diaphragm is from C3, 4, and 5 cervical nerves. C3, 4, and 5 keep the diaphragm alive. We've all heard that as we're learning anatomy. So you can TL the cervical spine and then have the patient breathe in and out. And you may not find anything in the clear, but when you have the patient breathe in or out, then it may reveal a subluxation or fixation in those areas. Then, of course, you want to check, test for a Lovett relationship between C3 and L3. Also, of course, any thoracic, especially mid and lower thoracic fixations, subluxations, which provide sensory nerve supply to the diaphragm, and structurally is involved with the diaphragm stability and movement. So any kind of subluxation in the mid and lower thoracics can potentially affect the diaphragm. Or vice versa, the diaphragm can cause a locking of those vertebrae as well. So dorsal lumbar fixation, basically check the entire spine, but that area in particular. Pelvic subluxations, often you'll find dural torque, and that's going to affect the diaphragm as well. Remember, there's 3 diaphragms in the body. There's the cranial diaphragm, the tentorum cerebri, the trampoline that the brain sits on. There is the respiratory diaphragm, which we're talking about here, and then the pelvic diaphragm. All 3 diaphragms, as we breathe in, flatten. So it's just something to remember. And so the 3 diaphragms need to move in sync with one another. And often that's not happening with our patients because of gait disturbance, subluxations, bad posture, and I think more than anything, being in a seated, stuck, non-movable situation for hours at a time. That's gonna inhibit this normal flow of this normal synchronized flow of energy through the whole body. So, just moving on, you can palpate the ribs. Check for rib subluxations, check intercostals. There'll often be tenderness when there's been diaphragm imbalance. Have the patient contract neck muscles and test for weakening. I haven't found that to be as consistent with for diaphragm. It's certainly a good way to bring out hidden subluxations and fixations. And then the sternalis muscle can be involved because it can interfere with rib function, with the rib articulation with the sternum. So a couple slides here, slide number 17 and 18. We are trying to summarize how you would go about working with the diaphragm. So you would suspect the diaphragm being involved if the following things are found, which is pretty much everything. Switching, cranial faults, unclear pulse point findings. Session 5 we talked about if the pulse points just aren't clear, or you're getting no positive TL at the pulse points, or you're getting everyth's TLing at the pulse points. Have the patient breathe in and out and see if that changes. That can be an indication that the diaphragm and or cranial and or pelvic function is off. Remember, if you're testing pulse points and all of the pulse points are weak on one side, you check breath, check other things, but also check the wrist. A lot of times you're TLing a wrist problem or a problem with the radius or the muscles. There's something's going on there, and a lot of times you have to go in and work on the wrist and make the corrections there. And then a lot of times you'll find good clear findings with the pulse points. Shortness of breath and history of asthma, both that you want to check diaphragm function with these people. There's some great gentle manipulative techniques to help really get the ribs moving again and strengthen the breathing mechanism. Of course, anybody, and nowadays it's so common, anyone who's been in sympathetic drive, i.e. under chronic stress and for a while, that's a good indication. Gait imbalances, of course, any trauma or past or recent, especially a compressive trauma where someone's fallen, maybe landed and had axial compression up through their spine. IRT, very common with this part of the spine that can be affecting the diaphragm for years afterwards. And of course, digestive issues, which we'll talk a lot more about here in a little while about when we get into the esophageal discussions around the esophageal hiatus. And just anytime you see kyphosis, patients will be just kind of locked in their upper back. You're going to find diaphragm involvement there too. So our key tools for evaluation would be test breath holding, test chest expansion, evaluate the psoas length, function, strength, and then of course therapy localization to the meridian pulse points, CV/GV, can indicate you might have a diaphragm issue. You can therapy localize right to the Chapman's reflexes on the sternum. It's kind of general, but that you can, that can work. And of course, the favorite is TL. Patient TLs right to just under the xiphoid process. You can TL to the neurovascular reflexes on the head, the three that are on the head, and of course, breath in and breath out, which typically we talk about with regards to cranial screening, but you're also screening diaphragm, obviously, with breath in and breath out. And then treatment. In summary, normalize gait, normalize psoas function. Of course, that means you're also going to need to check the other pelvic muscles, piriformis, glute max, glute med, adductors. Correct subluxations, fixations, especially in the TL area, thoracolumbar area. Check and balance meridians. Correct abdominal muscle function imbalance. Often there's an imbalance between the right and left rectus abdominis, for example, or the right and left obliques. All of those muscles need to be evaluated when you're treating the diaphragm. And then, of course, visceral problems, which really I think are probably probably one of the more common things I find that are interfering with diaphragmatic function, hiatal hernia, and various other kinds of stress around the esophageal hiatus, and a lot of times constipation or liver congestion. There isn't any space in the abdominal cavity for anything extra. So when the colon is really engorged and the liver's swollen and maybe the stomach's not emptying well, all this extra mass is pushing up and interfering with the diaphragm's ability to flatten on breath in and breath out. It's just there's stuff in the way. Another thing to remember too with diaphragm, you always want to think about this, the tough, thick capsule that sits around the heart is firmly anchored to the diaphragm. So when the diaphragm flattens, it tethers and essentially elongates this pericardial capsule. So it's actually so there's a synchronization going on between the heart and the diaphragm as well. The action of the diaphragm flattening in inspiration and doming up on expiration creates a pumping effect to the pericardium. So in the torso, everything affects everything else. In short, you have to fix what you find. But this helps you dial in diaphragmatic function. So we're going to stop here for now, and the next clip we're going to move into hiatal hernia.